At the family medicine clinic, a 17-year-old male named Heath came in because of lower back pain. Clinical examination reveals lots of small growths on the face, light, flat patches throughout his body, and a darker raised patch on his forehead. Heath was adopted early in his life, and his family history is unknown. Abdominal ultrasound reveals an angiomyolipoma of the left kidney. Next to Heath, there's an 8-year-old child named Sylvia. Sylvia complains of difficulty seeing what the teacher is writing in school. She also has a purple mark that covers the forehead and her right upper eyelid. Eye examination reveals increased intraocular pressure in the right eye. Her medical history includes an episode of seizure when she was 5 years old. A brain MRI is ordered and reveals brain atrophy. Finally, there's a 45-year-old male named Austin, who came in because of a ringing sound in his ears and a gradual loss of hearing. Brain MRI reveals bilateral masses on the cerebellopontine angle. Okay, so all of them have a neurocutaneous syndrome. Neurocutaneous syndromes primarily affect the nervous system and the skin. They include Sturge-Weber syndrome, tuberous sclerosis, neurofibromatosis type 1 and 2, and von Hippel-Lindau disease. For the exams, remember that Sturge-Weber occurs due to sporadic mutations, while tuberous sclerosis, neurofibromatosis type 1 and 2, and von Hippel-Lindau disease are autosomal dominant conditions. Alright, now let's take a closer look at these different disorders, starting with Sturge-Weber syndrome, which is also known as encephalotrigeminal angiomatosis. During week 6 of development, as the cephalic portion of the neural tube grows, a network of tiny blood vessels called a vascular plexus develops. There's a gene called the GNAQ gene, which codes for a guanine nucleotide binding protein that is involved in the development of that plexus. Normally, around week 9, the GNAQ gene stops getting expressed, leading to the regression of the vascular plexus. But in Sturge-Weber syndrome, a sporadic mutation occurs that lets some cells keep making GNAQ proteins. The mutated cell then replicates over and over, so all of the cells that descend from it have the mutation. The earlier the mutation arises in embryological development, the more tissues will be affected, since more tissues will originate from the mutant cells. This is an example of somatic mosaicism. This means that individuals have some cells in their body with the mutation and others with the normal gene. Now, as the GNAQ proteins accumulate, it results in the excessive growth of capillaries and tissues that derive from the ectoderm, especially the brain, eyes, and facial skin. The most common presentation is unilateral and complete disease, meaning it affects both the brain and the face on the same side, and most often the eye is not involved. Okay, moving on to tuberous sclerosis. This disorder occurs when there's a mutation in either the TSC1 gene on chromosome 9 or TSC2 on chromosome 16. TSC1 encodes for the protein hamartin and TSC2 for the protein tuberin. These two proteins combine to form hamartin-tuberin complex, which binds to and inhibits another protein called mechanistic target of rapamycin, or mTOR. Normally, mTOR increases cell proliferation, and so the hamartin-tuberin protein complex acts as a tumor suppressor. So when there's a mutation in the TSC genes, it causes an altered hamartin-tuberin protein complex that's unable to switch off mTOR. As a result, benign tumors and growths made of a variety of cell types called hamartomas form throughout the body. Also, the lifetime risk of cancer is increased. The brain and the skin are usually affected the most, along with the kidneys, heart, lungs, and eyes. Now let's move on to neurofibromatosis. There are two types, type 1 and type 2, and they're caused by mutations in the NF1 or NF2 gene, which are found on chromosomes 17 and 22 respectively. For the test, remember, NF1 goes with chromosome 17, and NF2 goes with chromosome 22. Normally, these are tumor suppressor genes that code for neurofibromin and Merlin proteins. Myelin is a protein found in the cytoskeleton of neurons, and its tumor inhibitory mechanism isn't fully understood. You're much more likely to be asked about the mechanism of type 1 neurofibromatosis and neurofibromin, which inactivates the RAS pathway. The RAS pathway takes part in many other signaling pathways responsible for cell growth, so dysregulation leads to growth of neurofibromas, which are benign, fibrous tumors that originate from neurons. For neurofibromatosis type 2, a high-yield fact is that it mainly causes schwannomas, which arise from Schwann cells. Finally, von Hippel-Lindau disease is caused by a mutation of the von Hippel-Lindau or VHL gene that is located on the short arm of chromosome 3. The VHL gene is a tumor suppressor gene that codes for proteins in charge of degrading a transcription factor called hypoxia-inducible factor, or HIF. HIF is responsible for upregulating genes that code for platelet-derived and vascular endothelial growth factors, or PDGF and VEGF, both of which promote new blood vessel formation and cell growth. In VHL disease, this tumor suppressor gene is mutated or deleted, causing an increase in a hypoxia-inducible growth factor, which increases the levels of PDGF and VEGF and ultimately the risk of tumor formation. So, VHL disease is characterized by the development of benign and malignant tumors in various organs, such as the eyes, kidneys, adrenal glands, CNS, and pancreas. Alright, now all neurocutaneous syndromes typically present with skin lesions, neurological signs, and formation of various tumors, but each of the neurocutaneous syndromes have symptoms that are special to them and can help you identify them. Let's start with Sturge-Weber syndrome. The first high-yield symptom is the characteristic nevus flammeus, which is a non-neoplastic birthmark. This is also known as a port wine stain, and it's a purple mark on the face in the areas innervated by the trigeminal nerve. The trigeminal nerve, especially the ophthalmic and maxillary distributions, are involved because during embryological development, it's one of the first cranial nerves to develop from neural crest cells. Typically, the port wine stain covers the forehead and upper eyelid on one side of the face, but in some individuals, it covers the whole face. Now in the brain, some individuals develop leptomeningeal angiomas, which are vascular malformations in the meninges that lead to pooling of blood, impaired venous drainage, and brain ischemia. Ischemia causes brain atrophy, which relates to the extent of neurological deficits. These include developmental delay, seizures, and muscle weakness or hemiplegia on the side opposite of the port wine stain or on both sides if the disease is bilateral. The brain can also develop areas of calcification on the brain gyri. This type of brain calcification takes on a tram track pattern because it literally looks like tramway tracks. Now, some individuals also have congenital trabeculodysgenesis, which is when the part of the eye responsible for draining the aqueous humor is underdeveloped. That leads to increased intraocular pressure and glaucoma that can cause reduced vision or even blindness in the affected eye. It is thought that the presence of episcleral hemangioma can also lead to glaucoma. Okay, moving on to tuberous sclerosis. So in the brain, the most common growths are glioneuronal hamartomas, also known as cortical tubers, and subependymal nodules. These lesions can cause neurological problems like seizures. Also, there's an increased risk of developing a subependymal giant cell astrocytoma, or SEGA, which is a type of cancer that can arise from the subependymal nodules. In the eye, hamartomas can develop in the retina, causing vision problems. On the skin, many small, red or flesh-colored papules called angiofibromas can appear, especially on the face. They might also have fibromas under the nails, known as subungual fibromas. Light, flat patches also appear on the trunk called ash leaf spots, and a distinctive dark raised patch on the forehead is a common feature. Another classical feature is a shagreen patch, which is a large, elevated, flesh-colored patch that often appears on the lower back. Another high-yield concept is that, in the kidneys, individuals with tuberous sclerosis can also develop bilateral renal angiomyolipomas, which are benign tumors comprised of blood vessels, smooth muscle, and adipose tissue. Angiomyolipomas can get really big, putting pressure on the kidneys and causing flank pain. In addition, they can bleed spontaneously. Individuals can also have lymphangioliomyomatosis in the lungs, where the lung tissue is gradually replaced by cysts, and this can lead to shortness of breath. In addition, they can develop cysts in the liver and the pancreas. Finally, in the heart, the most common cardiac manifestations are cardiac rhabdomyomas, which are benign tumors that usually affect the ventricles. If it affects the muscles of the mitral valve, it can cause mitral regurgitation. Okay, now moving on to neurofibromatosis type 1, also referred to as von Recklinghausen syndrome. Neurofibromatosis type 1 typically affects the peripheral nervous system, and more specifically, the nerves in the extremities and the skin. It causes numerous neurofibromas, sometimes hundreds. Cutaneous neurofibromas typically start forming in childhood and increase in number over time. They appear as painless, mobile lumps under the skin. Also, individuals with neurofibromatosis type 1 often have skin markings called café au lait spots, which are flat patches that are the color of milky coffee, and they're an important clue to make the diagnosis. These spots typically appear on the back, buttocks, and thighs in the first year of life and increase in number over time. In the eyes, there are Lisch nodules, which are tan, colored bumps on the iris. These nodules almost always appear by the age of 6, but don't usually cause any vision problems. In addition, neurofibromatosis type 1 is also associated with optic nerve gliomas. There's also an increased risk of other problems in the nervous system like seizures, learning difficulties, and malignant peripheral nerve sheath tumors. Occasionally, large neurofibromas can develop in the abdominal cavity, and they can press against nearby organs like the kidneys and impair their function. Also, pheochromocytoma, a tumor of the adrenal medulla, can develop. Because this tumor pumps out large amounts of catecholamines like norepinephrine and epinephrine, individuals can present with symptoms of sympathetic overactivity, such as headaches, sweating, palpitations, and hypertension. Neurofibromatosis type 2 is less common and presents differently. It's often limited to the central nervous system and the cranial nerves, so skin manifestation like subcutaneous neurofibromas and café au lait spots are much less common. Individuals typically develop schwannomas in the spinal cord or along the cranial nerves. The most common and high-yield area you need to know is the cerebellopontine angle along the 8th cranial nerve. The schwannomas here are called acoustic neuromas, and they usually arise bilaterally, which is very uncommon outside of type 2 neurofibromatosis. Acoustic neuromas can cause tinnitus, or a ringing sound in the ears, and gradual loss of hearing on both sides. Also, for the exams, remember that individuals with neurofibromatosis type 2 develop tumors called meningiomas. If they develop in the spinal meninges, they can compress the spinal cord, leading to pain, numbness, and weakness in the extremities. If they develop in the cerebral meninges, they can cause seizures or visual change and muscle weakness. In addition, individuals with neurofibromatosis type 2 can also develop ependymomas, which derive from ciliated cells that line the ventricles and central canal. Ependymomas can compress nearby ventricles and obstruct CSF flow, leading to obstructive hydrocephalus. Finally, individuals with neurofibromatosis type 2 can develop eye problems like cataracts or hamartomas in the retina. Alright, the last disorder is von Hippel-Lindau disease, which causes hemangioblastomas. These are benign tumors of the blood vessels that most often occur in the retina or the central nervous system, which includes the brain and the spinal cord. Hemangioblastomas in the retina can lead to blindness, while in the CNS, symptoms are based on the location. If the tumor is in the cerebellum, it will cause ataxia or loss of balance. If it's in the spinal cord, it can lead to numbness and weakness in the limbs. Since the hemangioblastomas occupy space in the brain, they can also increase intracranial pressure, causing symptoms like headaches, nausea, and vomiting. VHL is also associated with angiomatosis that consists of many cavernous angiomas that typically form on the skin, mucosa, or internal organs. Individuals with VHL can have benign cysts, which can arise in various organs like the lungs and the liver, and cystadenomas, which are benign, cyst-like tumors that originate from the epithelium. One type of cystadenoma is endolymphatic sac tumor of the inner ear, and it can lead to deafness and vertigo. For the test, also remember that cysts can develop in the kidneys and pancreas, but the more worrisome tumor associated with VHL is renal clear cell carcinomas that can appear bilaterally. Alright, as a quick recap, neurocutaneous syndromes occur when there's a mutation in one of the many tumor suppressor genes. A common theme is that these disorders cause neurological deficits and cutaneous manifestations, and they often present at a young age. Sturge-Weber syndrome is the only disorder caused mainly by sporadic mutation. Tuberous sclerosis, neurofibromatosis type 1 and 2, and von Hippel-Lindau disease are autosomal dominant disorders. Okay, back to the patients. Due to the presence of angiofibromas on the face, ash leaf spots on the trunk, and angiomyolipoma, Heath most probably has tuberous sclerosis. Diagnosis can be confirmed with genetic testing to identify a mutation in TSC1 or TSC2. Now Sylvia most likely has Sturge-Weber syndrome. She has a port wine stain on her face, glaucoma, brain atrophy, and seizures. To confirm the diagnosis, brain MRI can be done to look for leptomeningeal angiomatosis and tram tract brain calcifications. Finally, Austin probably has bilateral acoustic neuromas, which is a classic symptom of neurofibromatosis type 2. Genetic testing can be used to confirm the NF2 mutation.
With neurofibromatoses, neuro refers to the nerves, fibro refers to fibrous tissue, and oma means growth or tumor. So neurofibromatosis refers to fibrous tumors originating from the nervous system. The body's central nervous system is made up of the brain and the spinal cord, which are surrounded by three protective layers called the meninges. Part of the central nervous system are the cranial nerves, which originate in the brainstem and innervate the head and neck, as well as the spinal nerves, which originate in the spinal cord and supply the rest of the body. Each nerve is surrounded by a nerve sheath, which is produced by cells called fibroblasts. Inside each nerve, there are several fascicles, and each fascicle, in turn, is made up of several axons. The axons are the long projections of neurons that carry the information as electrical signals running up and down their length. Along the axon, there are cells called Schwann cells, which produce a myelin cover for the axon. The myelin helps electrical signals travel along the axon faster. Now, neurofibromatoses are genetic diseases which cause non-cancerous growths to form in the body's nerve tissue. And there are two types, type 1 and type 2. They're caused by inheriting faulty copies of either the NF1 or NF2 gene, which are found on chromosome 17 and 22, respectively. Just remember, NF1 goes with chromosome 17, and NF2 goes with chromosome 22. Both of these have an autosomal dominant inheritance pattern, so a child only needs one faulty copy from either parent to get the disease. Normally, these are tumor suppressor genes, which means they stop cells from dividing uncontrollably. So when there's a mutation in the gene, it leads to uncontrolled growth of fibromas, which are growths that have multiple cell types including neurons, Schwann cells, and other supporting connective tissue. Neurofibromatosis type 1 is also called von Recklinghausen syndrome, and typically affects the nerves in the extremities and the skin. It causes lots of neurofibromas, which are benign tumors that grow from the nerve sheath and are made of a mixture of Schwann cells, fibroblasts, and immune cells. Usually they grow just beneath the skin surface, but they can also grow along peripheral and spinal nerves. Cutaneous neurofibromas typically start forming in childhood and increase in number over time. They appear as painless, mobile lumps under the skin. On top of that, people with type 1 fibromatosis often have skin markings called café au lait spots, which are flat patches that are the color of milky coffee. These spots typically appear on the back, the buttocks, and the thighs in the first year of life, and increase in number over time. Also, on an eye exam, there are small tan-colored bumps called Lisch nodules that can be seen on the iris. These nodules almost always appear by the age of 6, but don't usually cause any sight problems. However, with fibromatosis 1, there's an increased risk of other problems in the nervous system like seizures, learning difficulties, and malignant peripheral nerve sheath tumors. Occasionally, large neurofibromas can develop in the abdominal cavity, and they can press against nearby organs, like the kidneys, and impair their function. Neurofibromatosis type 2, on the other hand, typically affects the brain, spinal cord, and cranial nerves. In neurofibromatosis type 2, skin neurofibromas and café au lait spots are less common. However, people with neurofibromatosis type 2 typically develop schwannomas, which are tumors comprising only of Schwann cells. These tumors can develop in the spine or along the cranial nerves. Most commonly, these tumors, which are also called acoustic neuromas, develop along the 8th cranial nerve. Acoustic neuromas can happen in individuals that don't have neurofibromatosis, but in fibromatosis type 2, they tend to happen bilaterally. Acoustic neuromas can cause tinnitus, or a ringing sound in the ears, and gradual loss of hearing on both sides. Individuals might also develop tumors called meningiomas, which are benign tumors originating in the meninges. If they develop in the spinal meninges, the meningiomas can compress the spinal cord, leading to pain, numbness, and weakness in the extremities. If they develop in the cerebral meninges, they can cause seizures or visual changes, as well as muscle weakness. People with neurofibromatosis type 2 can also develop eye problems, like cataracts, or small defects called hamartomas in the retina. Diagnosing neurofibromatosis is based on a physical exam focused on the skin, the eyes, and the ears. Tumors in the brain, cranial nerves, and spinal cord can be diagnosed using CT or MRI, and genetic testing can be used to confirm the NF1 or NF2 mutation. There's no specific treatment or cure for neurofibromatosis, but surgery can be used to remove tumors that are compressing nearby organs. Alright, as a quick recap. There are two kinds of neurofibromatoses. Type 1 is caused by mutation in the NF1 gene and causes cutaneous neurofibromas, café au lait spots, and Lisch nodules. Type 2 is caused by mutation in the NF2 gene, which causes bilateral acoustic neuromas and multiple meningiomas in the brain and spinal cord. NF1 goes with chromosome 17, and NF2 goes with chromosome 22. Diagnosis can be done with genetic testing to confirm the NF1 or NF2 mutation, and surgery can be done to remove some tumors. Sturge-Weber syndrome is a congenital neurocutaneous disorder named after William Sturge and Frederick Weber, the first physicians to describe it. It's neurocutaneous because it affects the brain and the skin. In fact, Sturge-Weber syndrome is also called encephalotrigeminal angiomatosis. Encephalo refers to the brain, trigeminal refers to the trigeminal or fifth cranial nerve, and angiomatosis refers to a vascular malformation. That's because in Sturge-Weber syndrome there are too many capillaries in the meninges covering the brain, as well as in some areas of the face that are innervated by the trigeminal nerve, like the forehead and the upper eyelid. Finally, in Sturge-Weber syndrome there's often a congenital mark, also known as a birthmark, called a port wine stain. Now, when the embryo is 1 week old, it has 2 layers of cells, a dorsal or outer epiblast layer and a ventral or inner hypoblast layer. During week 3 of development, the embryo undergoes gastrulation, where the cells in the epiblast layer form a 3-layered trilaminar disc with an ectoderm, mesoderm, and endoderm layer. The ectoderm is the dorsal-most germ layer, and through a process called neurulation forms the neural tube. From the neural tube, neural crest cells migrate to help form the central and peripheral nervous systems, as well as the cornea of the eyes and the epidermis layer of the fetal skin. During week 6 of development, as the cephalic portion of the neural tube grows, a network of tiny blood vessels called a vascular plexus develops to better supply that neural tissue. Now, there's a gene called the GNAQ gene, which codes for a guanine nucleotide binding protein, and that protein is involved in the development of the vascular plexus. Normally, around week 9 of development, the GNAQ gene stops getting expressed, and that leads to regression of the vascular plexus. In Sturge-Weber syndrome, a sporadic mutation happens in the GNAQ gene during embryonic development, and that keeps the GNAQ protein getting expressed even after week 9 of development. As a result, the vascular plexus doesn't regress like normal, and there ends up being an excess of capillaries in tissues that derive from the ectoderm, specifically those from the cephalic portion of the neural tube, like the brain, eyes, and skin on the face. Now, the GNAQ mutation happens sporadically in a random ectodermal cell, which then replicates over and over. So all of the cells that descend from that mutated cell have the mutation. This means that the earlier the mutation arises in embryological development, the more tissues will be affected, since more tissues will be developing from that mutant cell. The variation accounts for whether the Sturge-Weber is on one side of the body, or unilateral, or both sides of the body, or bilateral, and also whether it's complete, meaning it affects the brain and face, or incomplete, meaning that it affects just one or the other. So, for example, if the mutation happens very early in development, the syndrome will most likely be bilateral and complete. On the other hand, if it happens late in development, the disease will be unilateral and incomplete. Now, the most common presentation is unilateral and complete disease, so having both the brain and face affected on the same side. And most often the eye is not involved. In the brain, some individuals develop leptomeningeal angiomas, which are vascular malformations in the meninges which wrap around the brain. It's thought that these angiomas lead to pooling of blood and impaired venous drainage. And that makes it harder for fresh arterial blood to flow in, and this can cause brain ischemia. Over time, the ischemia causes brain atrophy, and the brain tissue can develop areas of calcification. In the skin, the most classic feature is a port wine stain, which is a purple mark on the face that's generally present from birth, as well as in the areas innervated by the trigeminal nerve. It's thought that the trigeminal nerve is involved because during embryological development, it's one of the first cranial nerves to develop from the neural crest cells. Typically, the port wine stain covers the forehead and upper eyelid on one side of the face, but in some it covers the whole face. Also, in some individuals, there are so many capillaries around the trigeminal nerve that it affects the eye on the same side, causing pooling of blood here as well, with obstruction of venous outflow ultimately leading to high episcleral venous pressure. Some individuals have congenital trabeculodysgenesis, which is when the trabecular meshwork, which is the part of the eye responsible for draining the aqueous humor from the eye, is underdeveloped. And this leads to glaucoma, which is increased intraocular pressure. Neurologic symptoms of Sturge-Weber syndrome are related to the extent of brain atrophy, and they include things like developmental delay, as well as seizures and muscle weakness on the side opposite of the port wine stain, or on both sides if the disease is bilateral. This is because each side of the body is controlled by the opposite side of the brain. As we just mentioned, some individuals also develop glaucoma, which can cause reduced vision or even blindness in the affected eye. Sturge-Weber syndrome is usually suspected when a baby is born with a port wine stain. And to confirm the diagnosis, brain imaging with a CT or MRI scan can be done to look for leptomeningeal angiomatosis, and the classical type of brain calcifications called tram track pattern, because it literally looks like tramway tracks. Treatment for Sturge-Weber syndrome is aimed at helping with symptoms, because there's no cure. Anticonvulsant drugs might be given to control seizures, and if those fail, individuals might get a hemispherectomy, which is where a large portion of the affected part of the brain is removed. Glaucoma can be managed with some medications like latanoprost, which is a prostaglandin analog that reduces intraocular pressure. And for more serious cases, surgery like a trabeculectomy can be done, which is when part of the trabecular meshwork is removed to help drainage of aqueous humor. Finally, for aesthetic reasons, laser treatment can be used to lighten or remove the port wine stain. Alright, as a quick recap, Sturge-Weber syndrome is a neurocutaneous disorder caused by mutation in the GNAQ gene. The result is an excess of capillaries in the areas of the face innervated by the trigeminal nerve, typically in the forehead and upper eyelid, and this is called a port wine stain. The eye on the affected side might also develop glaucoma, with increased pressure in the eye, causing reduced vision or even blindness. Finally, there can be leptomeningeal angiomas on the same side of the port wine stain, and that can cause brain atrophy and tram track brain calcification. Symptoms associated with brain atrophy show on the opposite side of the body, and include seizures and muscle weakness, as well as developmental delay.
Tuberous sclerosis is a genetic condition that causes growths to form in various body organs. This most commonly affects the brain, skin, kidney, lungs, and eyes. Normally, there are two genes called the TSC1 and TSC2 that help control the growth and division of cells in the body. TSC1 encodes the protein hamartin, and TSC2 encodes the protein tuberin. Both of these proteins are tumor suppressors, meaning they help slow down cell growth and prevent tumors. They do this by combining to form a hamartin-tuberin protein complex which binds to and inhibits another protein called mechanistic target of rapamycin, or mTOR. mTOR activity speeds up the cell cycle and increases cell proliferation, mainly thanks to its effect on protein synthesis. So, when mTOR is switched off by the hamartin-tuberin protein complex, it slows growth and division of cells throughout the body. Individuals with tuberous sclerosis have a mutation in either the gene TSC1 or TSC2, and these mutations have an autosomal dominant inheritance pattern. The mutations lead to an altered hamartin-tuberin protein complex that's unable to switch off mTOR. Because of that, benign tumors and growths called hamartomas form throughout the body. Hamartomas are kind of like tumors, but they're made up of a variety of cell types from the tissue where they arise, rather than a single cell type. In fact, if we think of the tissue like a sheet of fabric, a hamartoma is like a knot in the sheet. Benign tumors and hamartomas can form in any tissue, but the brain and the skin are usually affected the most, along with the kidneys, lungs, and eyes. On top of that, the lifetime risk of cancer is increased in individuals with tuberous sclerosis. That's because the rapidly dividing cells can develop additional mutations that eventually make these growths expand beyond the basement membrane and invade neighboring tissues. In the brain, the most common growths are glioneural hamartomas, also known as cortical tumors. They arise from supportive glial cells as well as neurons. Next most common are subependymal nodules, which are hamartomas that form under the ependymma, the thin membrane that lines the ventricles in the brain. Individuals are also at an increased risk of developing a subependymal giant cell astrocytoma, or SEGA, which is a type of cancer that can arise from the subependymal nodules. On the skin, many small growths called angiofibromas appear on the face. Individuals also have many small bumps called fibromas under the nails, known as subungual fibromas. Light, flat patches also appear on the trunk called ash leaf spots, and a distinctive dark, raised patch on the forehead is a common feature. Another classical feature is a shea-green patch, which is a large, elevated skin-colored patch that often appears on the lower back. Individuals with tuberous sclerosis can develop renal tumors called angiomyolipomas. Although benign, they can get really big and put pressure on the kidney. Because the kidney has a lot of blood vessels, angiomyolipomas do as well, and they can bleed spontaneously. Individuals can also have lymphangioliomyomatosis in the lungs, which are cysts where the normal lung tissue is gradually replaced by cysts lined by endothelial cells, which are cells that normally line the blood vessels. Finally, hamartomas can also form in the retina, which is the light-sensing part of the eye. Symptoms of tuberous sclerosis are often related to the hamartomas in the brain, which cause problems like seizures, learning difficulties, and cognitive deficits. A large angiomyolipoma can cause flank pain, and lymphangioliomyomatosis in the lungs can cause shortness of breath, and retinal hamartoma can cause vision changes. Diagnosis is usually made based on the skin lesions and can be confirmed with genetic testing to identify a mutation in TSC1 or TSC2. A head CT or MRI can identify hamartomas and tumors in the brain, and is usually performed regularly to screen for new lesions. Treatment of tuberous sclerosis is focused on the symptoms. Anti-epileptics are used to control seizures. Brain tumors are managed surgically or with chemotherapy, and behavioral and developmental problems are managed through therapy and psychiatric medications. Alright, as a quick recap. Tuberous sclerosis is a multisystem autosomal dominant genetic condition caused by mutations in genes TSC1 or TSC2. The mutations lead to an altered hamartin tuberin protein complex that's unable to switch off mTOR. It causes benign tumors and hamartomas to grow in the brain, the skin, the kidneys, the lungs, and the eyes.
Von Hippel-Lindau, or VHL, is a genetic disease that affects people of all ethnicities and is characterized by tumor development in the central nervous system, kidneys, adrenal glands, and pancreas. Alright, the VHL gene is a tumor suppressor gene on the short arm of chromosome 3. It codes for proteins that degrade hypoxia-inducible transcription factor, or HIF. HIF upregulates genes that code for platelet-derived and vascular endothelial growth factors, both of which promote new blood vessel formation and cell growth. In VHL disease, this tumor suppressor gene is mutated, which increases HIF, PDGF, VEGF, and ultimately the risk of tumor formation. VHL disease is about as common as Huntington disease, happening in 1 in 36,000 people. It's inherited in an autosomal dominant pattern, meaning that a VHL patient has a 50% chance of passing it on to each kid they have. 20% of VHL patients have a de novo or new mutation, meaning they're the first VHL patient in their family. Alright, the most common tumor type in VHL is hemangioblastoma, a benign blood vessel tumor happening in about 60% of VHL patients. In the central nervous system, these can happen in the retina, brain, and spinal cord. In the eyes, it can cause blindness by detaching the retina. In the brain and spinal cord, a tumor or the accompanying cyst causes problems when it pushes against surrounding tissue. For example, if the tumor is in the cerebellum, it can cause ataxia, or the loss of balance. If it blocks the flow of cerebrospinal fluid, intracranial pressure can rise, causing headaches, nausea, and vomiting. Less common are benign cysts and cyst-like tumors called cystadenomas. The most concerning, happening in about 25% of VHL patients, is the endolymphatic sac tumor of the inner ear, which can cause deafness. Cystadenomas can develop in the broad ligament in women and the epididymis in men. And incidental cysts can happen in the liver, lung, kidney, and pancreas in both men and women. Some tumors associated with VHL can be cancerous. Clear cell renal cell carcinoma, or RCC, happens in about 60% of VHL patients and can develop in both kidneys. Pancreatic neuroendocrine tumors grow in about 15% of VHL patients and can also metastasize. Two other typically benign endocrine tumors happening in about 20% of VHL patients are pheochromocytomas in the adrenal glands, and when they're found elsewhere, they're called paragangliomas. These tumors erratically pump catecholamines like norepinephrine and epinephrine, and individuals might present with sudden symptoms of sympathetic overactivity, like headaches, sweating, palpitations, and hypertension. A pheochrisis can happen when catecholamine levels are extremely high and can be fatal. VHL patients on average develop their first lesion by their mid-20s, but the age of onset varies with the lesion type. For example, hemangioblastomas usually happen earlier in life than renal cell carcinoma tumors. Not every VHL patient will get every type of VHL lesion, but they'll almost always get at least one. And since new lesions can develop repeatedly in the same organs, regular surveillance is crucial for improving quality of life and lifespan. Treatment recommendations are designed to preserve the function of the organ, and again depend on tumor type. For example, if you surgically remove RCC every time it appears, even when it was small and asymptomatic, VHL patients might quickly require dialysis. But once the cancer is about 3 centimeters, the high risk of metastasizing justifies the surgery. Retinal hemangioblastomas, however, should be treated when found, because each laser treatment does not cause appreciable vision loss. Alright, as a quick recap. Von Hippel-Lindau is an autosomal dominant disease caused by mutation in the VHL gene on chromosome 3. This leads to unregulated high levels of hypoxia-inducible factor, which causes tumor formation. VHL patients can develop lesions in many different organs, including the eye, ear, brain, spinal cord, kidneys, pancreas, and adrenal glands. Most of these are benign tumors, but they also have the potential to become metastatic, like bilateral clear cell renal cell carcinoma and pancreatic neuroendocrine tumors. Because VHL is highly penetrant and the lesions can happen repeatedly throughout a person's lifetime, routine screening and careful management is crucial.